everyone. Welcome to Pediatric Round Rounds. I'm Dr. Premonitory. Today's speaker is Dr. Tom Wilson, Section Chief of Pediatric Neurology and Assistant Professor of Pediatrics at Virginia Tech Carilion School of Medicine. Dr. Wilson is a native of Whitville and attended Emory and Henry College, where he still holds the record for the longest field goal. I want to see the picture. He attended medical school at Medical College of Virginia and completed his residency there as well, followed by a 3-year fellowship in child neurology at the University of Minnesota and a fellowship in EEG back at MCV. He came to Roanoke in 1985 after 1 year of private practice in Bristol, Tennessee, and has joined Carilion Clinic after 25 years of practice at Roanoke Neurologic Associates, where his practice included pediatric neurology, adult neurology, and director of the EEG lab in Roanoke. Dr. Wilson is recognized for his exemplary teaching abilities and was awarded the teaching award by the residency program 2 years ago. Please join me in welcoming Dr. Tom Wilson.
Good morning, everyone. Dr. Keys was just telling me that people said I was letting myself go. So what I found was beards grow really well on the mask. So if you see how it works, and here we are. So welcome. This is a different kind of talk for me. And the concept was discover some things about migraine that I found very elucidating and kind of stimulating. So I thought I'd share them with you. Also, there are a group of medicines that are now out there for migraine. We're not using it in kids yet, but it's going to happen. And I figure I need to know a little bit about it. And I won't teach you a lot about it, but at least let you kind of know where they're going. So let's get started. Nothing to disclose. I work for Carilion. That's all I do. It's interesting statistics. People frequently give a lot more, but somewhere between 2 to 21% of the population. And it's just some question about why neurologists talk about migraine a lot. It's personal. In my practice here in Roanoke before, we only had 1 out of 8 neurologists who didn't have migraine. And he was actually the best migraine treater of the whole group. So I don't know how that worked. I'm giving a little pretest. These are basically things to think about. I always like to know what the question is before we go through the discussion. So at the end, I know what answers I'm looking for. Calcitonin gene-related peptide only affects bone metabolism, true or false. Pulsatile migraine, pain arises in the temporal artery. Premonitory symptoms, which is a term many people aren't familiar with, are a form of aura. The newest migraine treatments are focused on, again, treating the aura, which is what we all want to use. I always like to talk about when it comes to migraine. Triptans work at 5-HT1B, 5-HT1D, and 5-HT1F receptors. Migraine is, with ours, the most common form of migraine, and migraines present a spectrum of related neurological processes. So do your own true and false and try to remember what your answer is, so when you get to the end, you can determine whether you actually knew this and didn't have to come anyway. Migraine is a whole bunch of stuff. We have a lot of tendency in medicine to put things into categories, and sometimes you kind of wonder how they get into those categories. And these categories based upon predominantly the fact that these occur in individuals who have. The ones that I think are the most interesting are the fact that we have these syndromes down here, which are particularly pertinent to pediatrics. They don't necessarily have headaches, but they do tend to cluster in patients who have migraine. My personal bias is that there's another condition down here that should be added, which is called transient global amnesia. Something we don't see in kids, but we see it in adults. My mother suffered it twice. And this is a very strange situation where a person will tend to wake up and seem to be fine. And then through the day, they are just kind of distant, and they take care of themselves, and they know what's going on, and their affect is kind of flat, and nothing really hurts, but they're very strange. So they come to the ER and they get their head CT and they get their MRI scan, and They take a little nap and they wake up and they're fine, but they have no earthly idea what happened that day. So it's a fascinating condition, but it happens more commonly in people who have migraines and family who have migraines. So it's an interesting condition. We tend to divide migraine into two types, with aura and without aura. We like to talk about aura because it's interesting, but most patients with migraine don't have aura. The characteristics of a migraine are unilateral, not always. In kids, it's frequently bilateral. Over half the time, it's still bilateral. It's pulsating. It's pretty bad. Something makes it worse, physical activity, and we have something with autonomic symptoms that's associated with it, and photophobia, phonophobia are frequently present. The aura, obviously, is a reversible neurological event. So without aura, with aura is less common than without aura. So one of the true falses has been answered. So what I want to do is provide information just about migraine. I want to kind of open migraine up more as a spectrum and give some conceptualization of how these things happen and how they're related, but also on the other hand say, is that really related, or is it kind of like other conditions which we put into the spectrum disorders and say, they kind of occur together, but they may not be that tightly related. And at the end, I hope you come up with the same conclusion that I typically do. But what that would mean is that you learn something, because what I've typically learned in this business is the more I learn, the more I realize I don't know, because there are more questions that come up than answers. This serves to raise these other issues. So if at the end you have more questions, then we've been successful. I'm going to approach this differently. The classic presentation is you start with the aura, and then you work down to the symptoms, and you work down to the headache, and you work down to the treatment. Well, I'm going to go the other way. I'm going to start peripherally, and then I'm going to go to the neuroanatomy, and then we're going to talk about aura, and then we're going to touch on treatments. So I'm going to divide this into three categories. The first is the pain, or the vascular migraine. And the pain in the artery is where the source of the pain is. The underlying vascular abnormality during that time is this sequence of events, the sterile inflammation around the arteries, and it's not the scalp arteries, it's the arteries in the meninges, because that's where most of the pain fibers actually exist. Mast cells get activated, blood vessels dilate, we get some plasma that leaks out, prostaglandins or arachidonic come out, pain starts to come down the trigeminal afferent pathway system, and we activate a system called the trigeminal vascular system. You know, we think about the trigeminal nerve as being an afferent nerve, but it also has efferent effect, especially in terms of autonomic changes on the blood vessels. It also activates the sphenopalatine ganglion and the facial nerve that goes out produces a lot of the autonomic symptoms, so they're closely tied. Now, this is what's happening at the vessel, but why is it happening at the vessel? It's happening at the vessel because there's been axonal release of certain neurotransmitters. These are the ones that people talk about the most, the neurokinin, substance P, CGRP, and others. And people like to talk about the CGRP because we can make drugs for that, and we've been successful with that. But it also is a very potent neurotransmitter. In fact, it's the most potent vasodilatory peptide. It comes from the trigeminal vascular and the autonomic nerves on the meningeal and cerebral arteries. In fact, the trigeminal ganglion, 50% of the nerves are positive for CRP, so they all have receptors. But it's not just that. There are multiple areas of the brain that have CRP receptors. The other thing that's interesting is here's a medicine, or here is a neurotransmitter that acts externally, extracerebrally. It's also intracranial as a receptor, but if you administer it peripherally, it doesn't cross the blood-brain barrier. So here we have a migraine treatment that we'll talk about in the future that doesn't cross the blood-brain barrier, so it must be working at the vascular level. Why do we think this is significant in terms of this specific transmitter? If you check the serum of patients in migraine attacks, CRP is up. It's also elevated in people who have chronic migraines compared to people without chronic migraines. The other cool thing is if you do a CGRP infusion, and if the person has migraines, they will get a migraine. If you do a CGRP infusion in someone who doesn't have migraine, they won't get a migraine. So, question. We have this chemical that causes these actions, but what is it about the migraine person that's sensitized to this specific chemical? CGRP affects mast cells, blood vessels, glial cells, trigeminal nucleus afferents. But the result is, again, this neurogenic inflammation, dural vasodilation, and how do I get rid of that? There we go. Dural vasodilation, prostaglandin release, and pain. So here's a peripheral vascular sequence I'm going to focus on because when we talk about pain, we always are going back to this process. So just a pictorial review of what we've just looked at. We've got the vessel, again, it's in the meninges. It's inside the skull, it's not outside the skull. The nerve is releasing, and it's also having an afferent effect going back into the brainstem. Excuse me. The afferent sensory pathway, again, is a trigeminal nerve. It has pseudo-unipolar sensory neurons, so things go in both directions. The upper cervical roots also go into that trigeminal nucleus caudalis. That trigeminal nucleus in the brainstem is a real long guy. So the cervical nerves actually go into the inferior portion of it. So if you activate that specific nucleus, the pain can show up in the back. So that's why a lot of people complain of neck pain or back of the head pain. Because the other most representative vessels are in the front of the head. So the migraine tends to be in the front, and a lot of times in the back. So this is anatomically based. It innervates blood vessels. And it converges on the trigeminal nucleus caudalis. Again, head and neck are affected. Now, from the trigeminal nucleus caudalis, it projects to the ventral posterior medial nucleus of the thalamus. From there, it goes to the cortex, but it also has expression and projection to subcortical areas, including the reticular formation, the cerebellum, and the limbic system. So, just kind of review, I'm going to show this picture a couple times just to kind of keep this into a big uniform set. So right now we basically have talked about this nice little blood vessel, the efferents from the trigeminal nucleus, and efferents from the superior petrosal nerve to the sphenopalatine ganglion, which is kind of back in the nasal cavity. Interesting, common treatment in people who are very migraine focused is a sphenopalatine block, and that can definitely block migraines. And with that, you're basically blocking this autonomic pathway. It seems to work pretty well. The head holds back, you drop lidocaine just so it gets back there, you numb the nerve, and the migraine can go away. So this is what we've talked about at this point. But we talk about things that happen inside the brain. So could the migraine really start inside the brain? Does it start outside the brain? Does it start in the cortex with the aura? Does it start in the brainstem? Where does all this gamish start? That's a question that we probably will not answer here today. Botox is an interesting thing. We always talk about Botox in terms of its cosmetic effect, but it's also used for migraines. And I mean, some of us are kind of skeptical, at least I was kind of skeptical. I said, oh, it's Botox. You just got muscle tension, you're giving the Botox, you're relaxing the muscle, that's all you're doing to make the headache better. Well, that's probably not true. That's much too simplified. Botox was initially approved in 2010 for chronic migraines, 15 days of headache a month, 8 of migraine. 1994 for tension, and injected in the scalp, but it doesn't cross the blood-brain barrier, so it must be working on the muscles, right? But there's a guy who's kind of looked at this, and I'm going to take it's relatively preliminary information, but it kind of is interesting because it ties things together and helps me mechanistically say, oh, this is how that works. Again, you can't take it as gold, absolute, proven, double scientific, but it's definitely interesting and it fits into some cognitive processing ways to explain what happens. But anyhow, if you inject Botox, it binds to C fiber nerves. It's in the site host, actually into the nerve itself. And the light chain in the Botox dissociates, enters the cytoplasm, and cleaves the SNAP25 protein. And that protein is critical for vessel binding and release. So the concept is Botox treats the migraines. You're putting it in the scalp. It's going to the nerve. It's going, wait a minute. It's going, how's it getting from the nerve here to inside where these meningeal vessels are irritated? That's interesting. So the mode of action is CGRP and other peptides can't be released. It interferes with formation of ion channels that enhance C fiber. There are some channels that I had never heard of, to be honest with you, until I did this investigation called TRPV1 and TRPV1A. And these are non-selective cation channels that are felt to be important in terms of C fiber and pain transmission. So they're getting a fair amount of attention at this point and where we can go with that in terms of treatment. But anyhow, this is all affected by this little protein that comes in the Botox and goes in the nerve. So here's the picture that kind of describes this process. The explanation was, okay, we're going to give the Botox here. Oh, you know what? I actually found some nerves that go from the scalp through the sutures and go to the meninges. So this is how Botox is getting in and treating migraines. I'm giving the Botox out here. It's going down here. It's preventing the release of all these nice neurokinins, CGRP, et cetera, et cetera. And if I'm not getting the release here that was caused by something, then I'm not having the irritation, I'm not having the migraine, I'm not having the pain to go down the trigeminal ganglion. So now the Botox has treated my chronic migraine. Now, migraine works for a few months, and that's because the Botox works for a few months, and the toxin stays within the nerve. So it's a nice, clean explanation and understanding of this process. Now, if we believe that there actually are these nerves that pass through the sutures, that could have some other implications of other things that could go on. It could be that we give the Botox and we block it. Now, what if something caused this specific nerve to be activated? And let's say the nerve is quiet, we're not having any of these neurotransmitters coming out, but something happens up here and stimulates this C fiber. And this C fiber releases neuropeptides. And we develop a migraine, which is pain going back in the trigeminal ganglion. Oh, wait a minute, this is a migraine that's not a brain thing. So does that mean that this isn't a neurological thing? It's a pain thing, so we need to send all the migraines to pain medicine? Is this a process that sets this off? Could this explain trauma? We see people who have never had a migraine, they hit their head, they have a concussion, and now they have migraines that are hard to control. You could imagine how if you had a tension type headache and the muscles are tight and you begin to release some of these neurotransmitters, you turn this C fiber on, it goes in, turns on the migraine. Pain in the TMJ frequently can cause this. Probably if you look at the pattern of most of the kids who come to our office with headaches, you'll see that Katie will say, oh, it's a mixed headache pattern. They have a tension type headache and a migraine. And the pattern typically goes like this. 3 or 4 days a week, I have this kind of headache. It's not awful, but it's there in the morning. It gets going as the day goes on. And then sometimes I get this headache that's throbbing. I get sick. I have to lie down. I have to go to sleep. So it's not uncommon for the tension type headache to progress to a migraine headache. So this will be an interesting mechanism for that. And there's no R involved. There's no neurological stuff that goes with it. And it's peripheral to central as opposed to central to peripheral. So that's one concept. There's another concept to explain other factors that we see with migraine. We've talked about this basic neuroanatomical process, and the concept goes something like this. Let's say that we have a stimulation of this process and the meningeal vessels are irritated, and we're having the pain come out the C fiber, and instead of it's going in afferently, we have an efferent spread of this neurochemical process, release of neuropeptides, but it's also releasing these neuropeptides on the scalp vessels. So now the scalp vessels are hurt. So now the pain also comes back into the trigeminal nucleus. So we have pain coming from the meningeal vessels, pain coming from the scalp vessels. That would be a nice little explanation for how aura causes migraine and how migraines cause allodynia. Allodynia is when the scalp becomes tender. I have a migraine, it's inside, it's on the meningeal vessels, but after you have migraine, the scalp can be tender, it hurts when you just push on it. So if the migraine's intracranial meningeal vessels, why does it happen that it hurts out here? Well, it could be we have a sensitizing process here. The other thing that can cause these vessels to be activated are pressure. Pressure on the dura specifically can set off migraine headaches. So if we're going to say, hey, this is a possibility, this could explain how auras cause migraine, with the concept being that the aura is a neurological process affecting the neurons in the cortex. And this neurological process affecting the neurons in the cortex is also stimulating the C fibers to become activated and setting off the migraine at the surface of the vessel and the aura. We don't have other good explanations for why the aura causes migraine. I want to talk about that in a few minutes too. So it's kind of interesting with this proximity that this aura is causing the activation. And this sort of process could say, well, that's how the aura causes the migraine. It's also when we have patients who have pseudotumor. You know, we think about a headache of pseudotumor. Well, you're having a headache because your pressure is too high. Well, a lot of the patients that we see in kids, especially, they come in and they have huge pressures, they don't have headaches. There are other people who have low pressures and they do have headaches. The concept is maybe these people have a tendency toward migraine, and the pressure is pushing up into the meninges and causing, again, this local migraine pattern. There's the pseudotumor pressure headache, which is typical, a real pressure headache. There's nothing I can do. The headache's there until it goes away. It's just an overall global headache. But the more chronic headache that happens with pseudotumor has all the characteristics of migraine. And we frequently treat it as a migraine. So it's a separate kind of headache from the pseudotumor itself. And then another explanation for the allodynia, sensitizing to the scalp and the migraine. So it's an interesting concept to think of pathophysiologically. So that's the pain part of the migraine. Now I want to talk about the subcortical migraine. I made up all these terms, so don't look them up if they're there. Somebody else copied me. No, I'm just kidding. So we looked at the anatomy again. We talked about the vessels. We talked about the trigeminal nucleus. We've talked about the trigeminal nerve, the superior petrosal nerve, but there's this whole gamish up here called the brainstem. You know, is it related to this? We're going to talk about that a little bit. It was long held that migraines began in the periaqueductal gray. As you know, it's distributed where it says. It's around the aqueduct and it's gray. So it's that long strip of gray matter in the brainstem going up into the midbrain, which we all said, oh gosh, there's no nucleus there, I don't have to learn that. And we called it the reticular formation and said, well, that's good. As long as I don't have to memorize where that stupid nucleus is, I'm just going to say it's cool. But it's gray matter, so there's a bunch of neurons distributed in there, and everybody thought that that's where migraine started. Why did they think that? Well, back in the 90s, people were using stimulations to treat pain. And one of the stimulations was to stimulate the periaqueductal gray, just around the base of the fourth ventricle. And what they found was if they stimulated that area, they get migraines. We found the source of migraines. We found the place that it starts. Well, that's not going to be enough to prove that. So they also began to look at it from a metabolic standpoint. Excuse me. And what they found out was, indeed, this area is more active as migraines begin. It also has increased metabolic activity. When you have a migraine, it also has increased blood flow. PET scan has shown that the activity localizes to the dorsal pons. It's been shown that the ipsilateral trigeminal nucleus is also active, which is, again, in the dorsal pons in that gray matter. And in this area, triptans, opioids, DHE, they all bind to that area. And calcium channelopathies are also in this area. This is a great place to say, okay, this is where the migraine starts. Again, we open the question, great, it starts there, but what turns it on? What's the switch? Why does it start there? We talk about the R, which is the neurological stuff of a specific speech issue, a visual issue, a hemiplegia issue, which is more of a cortical kind of thing. But we don't talk about what we call premonitory symptoms very often. And these are things that those of you who have migraines, this is kind of strange. It just happened. You can frequently say, I'm going to have a migraine today. And I just kind of feel weird. And before some of my migraines, I just see like I have to yawn, and I yawn, and I yawn. And it's not uncommon to have craving for some food that you don't normally do, or just really want to eat. Your appetite goes up, your appetite goes down. You're sleepy, you feel fatigued. And it's interesting how migraines are cycled, aren't they? Most people don't have a migraine every single day. Again, migraine in one person is not the same as migraine in another person. So they tend to cycle. They can be monthly, diurnal, and menstrual. Now, if we look at some of these symptoms, yawning, appetite, sleep, cycling, those of us who think neurologically say, when we like to localize things, well, where do we localize that? I localize that to the hypothalamus. So maybe that's the place that the migraines really started. So it was a very interesting case of one patient where this person said, okay, I got migraines, doc. You can do an MRI scan on me every single day, every morning for 30 days. I'm not going to take any medicine for migraine, and you can see what happens with my migraine. And she had 3 migraines during this time. And for the day prior to the migraine, the hypothalamus acted up first. No headache was present, but the hypothalamus was the site of activity. And then this projected down to the spinothalamic nuclei, the dorsal pons, that periaqueductal gray that we talked about before. Okay, well, what turned the hypothalamus on? That's the question we asked, even though we have the answer of it. Yeah, the hypothalamus is part of that. Is this saying every person starts the same? No. People's migraines probably start in different places in different ways, but if you have a lot of premonitory symptoms, it probably starts in the hypothalamus. Childhood periodic syndromes, these are some interesting things that we love to see in neurology because, you don't have to worry about, your torticollis, your vertigo, you don't have to worry about it, it's migraine. And they look at you crazy, but I didn't have any headache. But we put this into the same category, and if you look at what these symptoms are, paroxysmal torticollis, obviously torticollis that occurs suddenly, comes and goes away. Is it a migraine? Well, it happens in people who have migraines, whose family who have migraines, and you don't have another explanation for it, and it goes away with time. Benign paroxysmal vertigo, the same thing. The babies will wake up, and they're throwing up, and they're pale, and they may have nystagmus, and it goes and goes, and they come in because what's the cause of this, and 2 or 3 hours later it goes away, and they're perfectly fine. And mom and dad has migraine, so it must be part of migraine. Abdominal migraine, we all hate that because we don't know what that is it irritable bowel syndrome or what. But if it's abdominal migraine, it kind of follows a migraine pattern. It comes, it goes, but they don't necessarily have headaches, cyclic vomiting. So you can see how all of these could come from that subcortical anatomic substrate that we just talked about, being the midbrain, the pons, and the medulla. So we've talked about this, and now we're talking about the hypothalamus down in the periaqueductal gray, all of which have connections down to the trigeminal nucleus. So are we really seeing a syndrome that sometimes is just limited to here, sometimes it goes down to here, sometimes it starts out here, sometimes something else starts at here in the trigeminal nucleus? Oh, wait a minute, we haven't talked about R. So the thing that people like to talk about. So let's see where we're going to go with that. So this is what I call the aura migraine, and I say it's eloquent cortex plus. We talked about where these things all lie. We talked about the vascular. We talked about the subcortical. Now let's talk about the fun part. Well, kind of fun part, because anatomically it's fun. What happens with an aura, and this is well accepted, is there's a specific spread of activity. And these are manifest by these specific syndromes. So this time we'll talk about the clinical syndrome first, then we'll kind of go how we get there. Acute confusional migraine, person comes up, they're confused, they just really look like they're encephalopathic, fairly short term, it goes away. We say, oh, did they have a seizure? Are they postictal? Or is it acute confusional migraine? Family history of migraine, EEG is normal, clinical exam is normal, the patient slipped, it went away, can't find anything else, so it's okay, this is neurology, we're smart, it's acute confusional migraine, because we don't know what else to call it, so we're going to go with it. Hemiplegic migraine is very interesting because people actually develop hemiplegia, paralysis on one side. They come to the ER, they get MR after CT because they look like they've had a stroke. This is definitely due to glutamate. And we know what the pathophysiology and genetics of this process is affecting the cortex. Alice in Wonderland syndrome, there's a sudden change in the vision where people look at things and they look really small or really big, and they may be a little confused, but it's this true visual disturbance that is just like Alice in Wonderland disturbance. And we all have to talk about visual migraine. Anything that happens in the visual cortex you can get from the migraine. Dysphasic migraine, have difficulty talking. When I have my migraines, truly I get dysphasic, and I can't tell what people are, understand what people are saying to me, and I can't get the words out. I think that's why neurologists go into neurology. They're trying, like most of us, we're trying to figure out what's wrong with us. And, you know, people said that about psychiatry too, but I won't say that myself. Pediatricians are still trying to stay young. Yes. I think it works too, actually. And then transient global amnesia, which I talked about before. You can imagine how this would be fitting into that process as being a cortical disturbance. So this is caused by cortical expression. I'll say it used to, when I first learned about it, it's called cortical expression of Liao back in, 82 or something. And anyhow, this guy, what happens is there's this literal depolarization. There's initial hyperpolarization, increased blood flow, and then decreased flow, and people characterize it as a slow seizure. So, and for some reason, in some part of this person's cortex, the neurons become active, and then they get hypoactive, and they decrease, and it spreads. And the physiologist in South America figured out, I'm going to figure out how fast this is going. I'm going to use my aura. He had visual aura, and he looked at how fast his visual aura progressed, and he correlated it with the spreading depression. So is this depolarization, this lack of function of the cortex over a period of time. There are all kinds of different reasons for this. We like to talk about glutamate as being the precipitant of spreading depression, because familial hemiplegic migraines all have mutations that would increase that. One mutation, type 1, is a calcium channel disturbance, and the problem with that one is too much calcium goes in, too much glutamate gets released, and it sets off this hyperactivity, and then it turns itself down. With 2, you have a ATPase abnormality, which you can't have normal uptake, reuptake of the glutamate once it's been secreted. And with type 3, it's a sodium channel disturbance where the neurons are overly active, so they release too much glutamate. Now that's a nice simplistic thing, but why does it happen at one time, not another time? If this biochemical genetic defect is there, why is it not always there? What is the complex group of things that set this part off? People also talk about potassium, so there are probably a lot of different things that set this process off. But this is what I like to talk about because we have that nice little genetic explanation. So I think there are multiple pathophysiologies of aura, probably though all ending up with this depolarization. So let's talk about this cortical spreading depression producing the aura. Oh, that's simple. You have this depolarization of the cortex, you have this neurological dysfunction, but you can have cortical spreading depression and you don't have aura necessarily. So is migraine caused by cortical spreading depression in a non-eloquent area of your brain? Is this activation in the hypothalamus that we talked about earlier actually cortical spreading depression of the hypothalamus? I don't know. The other thing is we talk about medications, and most of the ones that we give commonly are more directed toward the aura process. And medications that stop aura do help migraines, but they also help migraines without aura. So there's some correlation there. Now, we don't know, to be honest with you, with all these wonderful medicines that we give, the antidepressants, the anticonvulsants, the calcium channel blockers, the periactin, the cyproheptadine. We don't really know exactly what they're doing. We just know it helps. So we're doing something to make something do better. Sometimes I say we're just giving neuronal stabilizers to make the circuits work better. But anyhow, this is always something that fascinates me, and we'll have a study in a little bit. One of the hardest things to do is to prove a medicine helps migraine. Not because you give the medicine and it doesn't help. It's because when you do a placebo study, the response to placebo is so great. With the CHAMP study, that's okay, we're going to do a great study. We're going to compare placebo. We're going to compare Topamax. We're going to look at amitriptyline. We're going to do this great NIH study. And we're going to see which one of these is better. And what we found was, Topamax helps about 50%. Great. Amitriptyline helps about 50%. Great. Placebo helps about 50%. Uh-oh. The problem is we can't prescribe placebo, so we have to prescribe topiramate and amitriptyline. But it would be interesting, but we have a study that says placebo works great. And the studies with the CGRP blocking agents have also shown it's a very impressive response to placebo in migraine. So is that a cognitive expectation that's affecting the cortex, that's turning off this cortical spreading depression? Question mark. Okay, I think that's fascinating. Migraine without R frequently responds to NMDA blocking agents. So even though we talk about glutamate being a precipitant, or at least a part of the process of migraines, if you don't have the R, NMDA blockers, glutamate blockers will help that migraine. And then there's interesting neuromodulation we'll talk about a little bit, which are non-medical ways to treat your headache. And they're not just internet. I mean, they've actually shown to be effective and they're FDA approved. Okay, so we'll talk about treatments a little bit. The traditional treatment is we're addressing the R, because we see the R, we feel the R, we understand the R, we know what's going on. And the idea is we're decreasing the spreading depression. How are we doing that? I don't know. We're putting something in and we're changing the sequence of events of these cortical systems and these programs, and we're just making it not become pathologic. So we're going to presume it alters the connectivity. I call it a neuronal stabilizer. And these are antidepressants, anticonvulsants, beta blockers, calcium channel blockers, serotonin blockers, antihistamines, all of which do affect neurotransmitters within the brain, but no specific unifying concept. So that's the common way to treat migraines on a daily basis. Now, if we want to just break the chain of events of a migraine, then we tend to focus more on the serotonin receptors. And this is what the ergots in DHE do. They actually stimulate 5H1B and 1D receptors. We talk about this a little bit more, but the 1D will decrease the transmission of pain and decrease the release of CGRP. And the 1B receptors, we stimulate those, we help that blood vessel contract down a little bit. And this is the paranoid thing that we get to with people with heart disease and other potential vascular issues, and I don't think I want his blood vessels to go down, so that may not be the best drug for him. So this is a 1B serotonin receptor. And as you know, we give dopaminergic agents, we give antiemetics, Reglan, Compazine, and hey, that maybe breaks the chain of events. Or we can just go to sleep. Just give something so I can go to sleep, and when I go to sleep, my headache's going to be better. So we'll give a lot of medicines, knock the pain out, make you not nauseated, help you go to sleep. When you wake up, you're fine, but you still may have that allodynia, and that's not going to be unusual to have. And if you cough and sneeze, you're still going to grab your head like, oh my God, where did that come from? Again, the residual of this vascular sensitivity. Our vomiting. You know, we talk about vomiting being part of migraine, but there are a good number, and I'll say of us, who I've got the migraine, I just need to vomit because the vomiting will make the headache better. Not always, but there's a good percentage where that will happen. Or we just treat the symptom. We'll give you some medicine for the pain, give you some medicine for the nausea. Hopefully it'll go away or go to sleep. So we kind of have 3 different approaches to treating migraine. So what we talk about at this point is the new treatments that are out there. We talked a lot about CGRP in the vessel, and they've identified that we can do something about the CGRP. One of the reasons that CGRP has gotten all the attention is we talked about all the stuff that CGRP does in terms of the vessel, about how it's high when you have migraines, so it seems a great candidate. And it's the one they've had the most luck with treating too. So the others may also be, and there are drugs in the pipeline to treat the other neurotransmitters that work at the vessel level, but they've been harder to develop. So these are monoclonal antibodies, and there are 2 specific focus of the monoclonal antibodies. One is actually to the CGRP itself. The other one is actually to the CGRP receptor. So inject it, let's decrease the CGRP, you're not going to have as many migraines. Or we're going to give it a CGRP receptor, I'm going to block that receptor so the CGRP is going to get released, it's not going to be a problem. The other group, which actually started before the monoclonals, were small molecule CGRP receptor blockers called GPANs. These are more of a medicine kind of thing. They initially caused significant elevation of liver enzymes, so they kind of got put on the back burner. But now they're back up, that's been addressed. And then there's a receptor called the 1F receptor. Orgots talk about attack the 1B receptors and 1D receptors, but there's a 1F receptor. And this is a totally different receptor that the ergots and triptans don't affect. And this is the focus, this is the target of one of the new treatments. And then there are devices. There are 3 presently available CGRP antibodies which decrease the antibody. There's one that actually addresses the receptor. They all virtually work the same in terms of statistical probability of benefit. So there's not a great difference in terms of either any or these 2 types of antibodies. These guys are parenteral. Something good about these guys is you give it to it, and you're good for a month. So you don't have to worry about taking your medicine. The other thing that's interesting is if you give it sub-Q, it works within a week. If you give it IV, it'll work that day. So if it works for you, you can see how people say, whoa, that is really nice stuff. We haven't had any problems reported in the studies of kids. These studies are definitely are being performed, and it's really just a matter of time before we see these as being options, especially with the chronic migraine patients. So these are definitely going to be seen, so something to keep in your mind so you kind of have an idea of what these are all about when they show up. The small molecules are different. Again, they actually are medications that attack the receptors, the CGRP receptor. These are the ones that are presently available. These are in the pipeline and will probably be available soon. These are oral. They don't have the benefit of the antibodies where you inject them. These are pretty much you have to take them once or twice a day to treat the migraine. So they're not used as much as a preventative, but more as a new treatment for migraines. So when you see these things, that's part of the reason I did this, because I didn't know about these guys very much. So this is an opportunity for me to learn. So here are some studies that looked at the change, and these are not God's gift to migraine. So if we just look at how much benefit they actually gave, the black bar is the placebo, and this is the mean migraine days of an episodic migraine study. And different studies, basically, the point is that they all had benefit, but the placebo response is also very interesting. So let's take this, we're looking at, the mean migraine days decreased about, let's say 2.8, and we're down here at, we'll say 5. So 3-4 days a month, better than migraine. Now, it's across the board, and it's positive, and it works. So if you compare this, not to placebo, in other words, you don't take the placebo, then you're talking about 5 or 6 less migraine days a month, which can be very significant in terms of function. So they are all beneficial. And the other thing is a 50% responder rate. Again, placebo, we'll say 25%, and up to say 40%. So 15 to 20% over placebo, but compared to baseline, that's a nice number. 50 to 60% have shown a 50% improvement in their migraines. So they are effective. They don't make migraines go away, but they make them better. So we talked a little bit about mode of action. So the 1D receptors, the 1D inhibits CGRP release, blocks return of pain signal. The 1B receptors block vasodilation, and that's the triptans and the ergots. The 5-HT1F receptor primarily works in the brain. Everything else works outside the brain. But these guys go in the brain, and they block CGRP release, and they don't cause any vasoconstriction, so they're very popular from that standpoint. And lasmiditan is that drug. And this one's out there, very valid. You see it, watch the news, 7 o'clock news, 6:30 news, you're going to see it. It's going to pop up at least once a night. Here are the devices. These are interesting. They look kind of weirdo, but these are the ones that, I think these 3 are available, 4 are available. This is a transcranial magnetic stimulator, so you hold it to the back of your head. It has a specific sequence that you do. You can do it to be a prophylactic agent. If you do it regularly, you can decrease your number of migraines. It has a program that you can do it to stop your migraines. This is basically a transcutaneous nerve stimulation over the scalp. It has, again, a set protocol. You take it up, put the sticker on it, put the electrodes, set it to prevent or to treat migraine, and it helps. This is a handheld vagal nerve stimulator. You stimulate the vagal nerve, you send impulses into your brain, you disrupt whatever's going in there, and your headache gets better, or you have fewer headaches. Now, this is the one that is fascinating. And obviously, this is the one that's popular with the young kids. It's actually a band with the transcranial, with the TNS device. It goes on the arm. It has a program on your cell phone, and you have programs on the cell phone that you tell this thing when you want to stimulate. And it helps prevent migraine occurrence. It helps stop migraines. And again, it's working on the concept that we're sending messages to the brain, and we're disrupting this cycle of events so that now you don't have the migraine. The response to this has been similar to what the triptans has been. So I've never used these, but I think it's a fascinating process. Okay, so post-test. Obviously, calcitonin has a lot to do with other than bone. Pulsatile migraine is not in the temporal artery, it's in the meningeal arteries. The premonitory symptoms are separate from aura. The newest migraine treatments are not focused on the aura, they're focused on the nerve. The triptans work at 1B and 1D sites, whereas the new lasmiditan works at 1F sites. And the migraine with aura is less than half of patients who have migraine. And you may not believe me, but I think migraines are a true spectrum of different conditions that sometimes occur together and sometimes occur separately, and we have multiple different precipitants of this. And I have a bunch of other stuff I talk about, the timing's great. Okay. Any questions?
Repeat the question. You talked about being oral focused and treatment. Yet, at least 30% of people with migraines have oranges. So, I'm just trying to sort through that in my head. As far as,
I think that's definitely a point. Okay, aura is an eloquent part of the cortex. It's spreading depression, causes aura. This is a specific syndrome that's in a specific part of the brain that we know about. But since we know these other treatments also treat migraine, then do we have no idea what we're doing? Or do we really have the same pathophysiology of cortical spreading depression happening in the hypothalamus, happening in the periaqueductal ray, happening in the trigeminal nucleus? I don't know. Because we all feel comfortable when we've simplified something and we understand it. And once we understand it and we know what's going on, we're comfortable and we go with it. But at least in neurology, you kind of understand what's happening and then you understand what it could be, but you never really know, is that because something's overactive, something that's supposed to control this is underactive, or something 3 circuits back is totally different. So I start with the concept, and then I say, yeah, it was probably much more complicated than that.
I guess I'm trying to find out what I'm thinking. I guess my question is, if you have a patient with an aura and without an aura, do you treat it different? Or is the medication approach different? Or is it
No. And that's the reason I think that there's overlap that's there. And again, I continue to be fascinated by the CHAMP study where whatever you give seems to work about the same degree. Then you have some that nothing worked with. So to me, it's fascinating. So just a few more minutes. I'll just talk about some later slides. If you're interested, there are recommendations that have been made for use of the CGRP in pediatrics. It's in Headache 2018. A bunch of headache specialists in pediatrics got together and said, okay, we've got this new drug out there. Well, how should we use it? What should we worry about? And they say if we're going to use it in kids, they should have failed other treatments. And the drug companies are not even going to talk to you about it until they failed at least 2 or 3. 8 days a month. And initially start low, give it a month or so. If it's not working after 2 months, go high. If it's not working after 2 months, give it up. If it is beneficial, get them to 1 headache a week, and then you can stop it. CGRP, as we talked about, is working at the nerve, but it also has receptors throughout the body. So CGRP actually has an effect on CNS maturation. So there's a concern that if you just give CGRP blockers, are you going to change brain maturation? It also is important for uteroplacental function. If you don't have CGRP, then the placenta doesn't really maintain its. Remember we talked CGRP is a vascular dilator. If you don't have CGRP, the placenta may have some real problems. So it's definitely not going to be in someone who's pregnant. It does have an impact on bone formation. So it's that we need to monitor growth. It has an impact on glucose-insulin interaction. So blood sugars need to be monitored. It even has an impact on lymphocytes, macrophages, and mast cells. So there's a potential immunological impact of it. It can be pro or inflammatory, and it's a potent vasodilator. So the suggestion is that you are aware of these, and we monitor growth, and we monitor glucose, we monitor infection, don't give it to immunocompromised. Fortunately, none of these have really shown up in adults to be an issue, even though CGRP is an important factor. It hasn't really shown up there to be an issue. So again, this is my initial discussion in terms of, I had no idea how long this was going to last. The questions that we have in terms of vascular migraines, subcortical and aura. There's an interesting type of migraine that I just like to throw this one out to make you think, so at the end you're going to say, I know less than I did before, called ophthalmoplegic migraine. With ophthalmoplegic migraine, the person has typical, terrible, intense migraine headaches. It's very rare. I saw my one in follow-up who had it happen again last week, in fact. Terrible migraines, and then they present with total ophthalmoplegia of a nerve, usually the oculomotor nerve. So they come in, they've had these terrible, terrible, terrible migraines. Now the eye's popping out to the left side because the lateral rectus is working, but nothing else is. Nothing in the brain is messed up. And the terminology now for it is ophthalmoplegic neuropathy. The reason for that is imaging will frequently show that the oculomotor nerve is inflamed. That the oculomotor nerve is obviously malfunctioning and it's inflamed. It's a neuropathy, it's a neuritis. But they all start with this terrible, terrible migraine. And they tend to have a family history of migraine. So think about that a little bit. Think where that could go. And if we kind of take this whole process, you can say, okay, there's this terrible migraine, and that's coming from these vessels around the oculomotor nerve, maybe not in the meninges. And this inflammation is to the point that it's compromising the function of that nerve because it's with the headache and it's going to go away. And whether the treatment affects it or not, we don't know, but they all get prednisone. So again, we put these into the migraine syndrome. We pulled that one out because we see an inflamed nerve. We say that's not migraine. But is that a different type of migraine because you start with pain and you have a vascular abnormality? With migraine, you have pain and a vascular abnormality. So maybe it should belong in the migraine syndrome. Okay, thank you all. Time's up. Yes?